Welcome to Coffee with Kyle number 18. I'm Kyle Ridgway. Good evening. Show you the glass here. This is actually really another beer with Ridge, Cerebral Glass. Great brewery here in Denver, owned by a physical therapist actually. So, as they say, mistakes were made, but not by me. Well, in this case, in fact, errors were made by me. So in Coffee with Kyle number 16, I discussed the early adoption of ineffective treatments versus the late adoption of effective treatments and tried to parse out a little bit which one was potentially riskier. And one of the statistics that I packaged into a nice, essentially banal platitude was that it takes approximately 10 to 17 years for evidence to permeate into clinical practice. And well, we didn't delve into that nicely packaged headline deeply or completely enough, unfortunately. And it turns out that it's a bit more complicated than that. And so I was forwarded, thankfully, by my friend, colleague, and constant skeptic, Kenny Veneer, a nice article that was actually published by the Society for Medical Decision Making in October of 2017, and it is titled Evidence-Based Claims About Evidence, and that is authored by David H. Howard, PhD. And I think what I'm going to do is read a few excerpts from that and then respond to them as reading that article and listening to Kenny give me some insight on it made me realize that this statistic that is well presented and maybe oversold is that it takes 10 to 17 years for evidence to permeate into clinical practice. So, back to the article. And I quote, "Presentations on evidence translation in healthcare often begin by citing the statistic that it takes 17 years for evidence to diffuse into practice. The source of the 17-year estimate is a paper by Bolus and Bourne published in 2000 in the Yearbook of Medical Informatics. The authors identified 9 mostly primary care services supported by evidence from randomized control trials and calculated, based on the trial's publication dates and current levels of use, that it takes 15.6 years for use to reach 50% in general clinical practice. Including the time from submission to publication, 1.4 years, brings the implementation lag up to the familiar 17-year figure. Although the paper was published in a relatively obscure venue, it was mentioned in the Institute of Medicine's Crossing the Quality Chasm report and has been cited more than 800 times. But this figure underestimates its influence because some authors reference the Institute of Medicine report instead. The 17-year figure is cited by policymakers, including Agency for Healthcare Research and Quality Director Andrew Benman, former White House Officer of Management and Budget Director Peter Orszag, and also in the popular press. Back to the article. Evidence is a somewhat amorphous term, but Bolus and Bourne focus on the adoption of treatments following the publication of landmark trials. Some treatments are tested in multiple high-quality trials that produce conflicting results, but these cases are rare. The evidence for many treatments rests on observational studies or decision analyses, but if trials do not affect practice, it is unlikely physicians will respond to studies that are lower in the hierarchy of evidence. The publication of landmark trials produces the cleanest test of the impact of evidence. Understanding how evidence from trials affects practice is important, not only for identifying opportunities to improve care, but also, more broadly, for assessing the performance of the health system. Bolus and Bourne's findings suggest that the system is deeply flawed. Physicians, and I would add to that all healthcare clinicians, ignore evidence that could benefit their patients. However, despite its troubling implications, their work has received little scrutiny. Sidebar there, I'll agree with that. I see people cite this all the time, and the only scrutiny that I hear is usually from people who claim that clinical practice is actually ahead of the research, and research is just catching up, but it's a different topic for a different day, and I covered a little bit of that in a different Coffee with Kyle. Back to the article. It turns out there are a number of problems with the 17-year estimate and how it is used. some of their utilization estimates are low and not well referenced. For example, they assumed that only 20% of diabetic patients had foot exams in 1998. According to the Centers for Disease Control and Prevention, the actual rate was closer to 60%. They use an estimate of mammogram rates from 1997, which, when combined with their assumption that the rates increase linearly, implies that mammogram rate reached 50% in 1993, when in fact rates reached that level in 1990 or potentially earlier. Physicians can apply evidence to patients only who show up. Most of the utilization measures are calculated using broad-based denominators. For example, all adults, adult health plan members with diabetes, etc. They include patients who do not have regular checkups. Consequently, they partly reflect the behavior of patients and do not isolate the impact of evidence, or rather, what I would say is the translation of evidence into physician or provider decision-making. Also, wide-scale delivery of some services requires an extensive infrastructure, such as manufacturing capacity and distribution systems for vaccines. Diffusion rates for these services do not tell us much about how physicians respond to evidence generally, yet the 17-year estimate is typically quoted without caveat. And I think that's a nice point that I want to hit upon quickly, is that we kind of assume that evidence is published, therefore it should be translated, and that there's just this singular step or singular jump in implementation. As I've talked about before, implementation science or implementation itself is kind of its own can of worms, so to speak, in that there's many things that affect implementation at the provider level, at the system level, at the patient level, at the incentive level, at the payment level. And I think the author does a nice job here of kind of highlighting the fact that even if the evidence is robust and fairly conclusive, and even if physicians or providers or other healthcare clinicians read it, understand it, and want to apply it, there's other system and implementation factors that may come into play outside of cognitive bias and the backfire effect and history of how people usually do things. It may actually be infrastructure. It may be payment. So there's a lot of complexity to why the lag exists and whether the estimate is accurate. So I think that's a nice point. Back to the article. Dissemination and implementation science researchers have latched onto and amplified the 17-year implementation lag estimate to highlight the relevance of their field. I think that's potentially making an assumption. They may highlight it. Who knows the intent there? I don't want to assume intent and why they're highlighting it. Their counterparts in behavioral economics have also embraced the notion that practice changes slowly to illustrate the applicability of behavioral economics to medicine. They claim that physicians display belief persistence and confirmation bias. Physicians are slow to let go of long-standing beliefs in response to new evidence and irrationally overweight evidence that is consistent with their perceptions. This is a big sentence to unpack, I think. Yes, that has been claimed, and I think there's a dichotomy here. That is for sure true because that we know that that's how human nature works. Now, maybe on the grand scale of that behavior of belief persistence and confirmation bias, maybe physicians and other healthcare providers and scientifically trained and minded people may be a little bit less prone to that. I don't know the data on that. I would be surprised if it's significantly better than other populations. But camera issues per usual. But the other thing to take into account here is that even if that is true, that's likely not the sole explanation or the sole factor. And I think that's a great point to bring up, is that even if providers do exhibit belief persistence and confirmation bias, that doesn't mean that there's other factors at play that are affecting why there could be a lag in implementing evidence into practice. All right, back to the article. However, discussions of this phenomenon are often long on theory and short on real-world examples. The examples that are commonly cited to illustrate how physicians discount new evidence, such as prostate-specific antigen screening and breast cancer screening for women under the age of 50, are notable mainly because changes in screening recommendations were prompted by a reassessment of the existing scant and conflicting evidence base rather than the release of new evidence from a randomized trial. Another interesting point. This is what I think is the interesting thought, or the interesting counterfactual or dichotomy. Back to the article. Counterexamples are discounted or ignored. Though there are cases where evidence is, let me state that again. Counterexamples are discounted or ignored, though there are actual cases where evidence has led to rapid changes in practice. One such trial, which randomly assigned breast cancer patients with 1 to 2 positive sentinel lymph nodes to undergo a complete axillary dissection or no additional treatment following lumpectomy, is a case in point. There was a line in the proportion of breast cancer patients meeting the trial inclusion criteria who had 8 or more nodes examined, a proxy for the receipt of an axillary dissection. The share of patients who had 8 or more nodes removed decreased from over 50% to below 30% in a matter of months, which is a remarkable practice change, by the way, if that data is accurate. In fact, treatment started changing shortly after the results of the trial were presented at a medical conference, even before the trial was published. Now, there are characteristics, this is from the article, of the procedure that may have facilitated the translation of evidence into practice. The audience for the evidence was a close-knit community of specialists. Physicians who performed axillary dissections did not pay a price in terms of fame or fortune, and the procedure is associated with side effects. And so patients faced tangible harms that were likely, or tangible harms from treatment that I would postulate were likely easily observed and probably were observed by the physicians. This is another one where I think the goes back to a previous Coffee with Kyle where I talked about which is more dangerous, the early adoption of ineffective treatments or the late adoption of effective treatments. This actually ties this whole concept together with the evidence lag. Back to the article. There are, of course, cases where high-quality evidence has failed to change how physicians treat patients. For example, use of tight glycemic control in patients admitted to intensive care units did not decline after a trial found that it increased mortality. Interestingly, the reason that practice was uptaken or implemented was a trial that suggested very tight glycemic control, blood sugar control in the ICU, could improve mortality outcomes. That evidence was rapidly implemented into clinical practice, and then as more evidence came out, it was actually shown that tight glycemic control was associated with increased mortality, but the de-implementation was actually slower than the implementation, which is one thing that I talked about or potentially harmful treatments, is that it may be remarkably hard to de-implement them for a variety of reasons. Back to the article. Rather than trying to define a one-size-fits-all rule about the speed at which results are translated into practice, researchers should instead try to build a more robust knowledge base about the factors that influence how physicians and other providers and clinicians respond to evidence through observational analyses and interventional dissemination studies. Author goes on to ask a few questions here. How does the quality of evidence affect the uptake of findings? Are there characteristics of trials that predict rapid uptake? How does uptake vary based on physicians' training, compensation scheme, practice environment, and other modifiable factors? Are studies that highlight patient harms more influential than ones that emphasize equivalence of a primary endpoint? The answers will help investigators and funders design better trials and dissemination strategies, and policymakers better healthcare systems. In the time, the 17-year implementation lag estimate should be laid to rest. There is still a lot of work to be done to make evidence-based medicine a reality. Acknowledging that sometimes evidence leads to rapid change does not negate that fact. So that was a great article that kind of changed my perception and broadened my lens and deepened my considerations of the evidence lag, or the lag time between evidence findings and the translation into routine clinical practice. And I think really what it showed to me is that implementation, behavior change, knowledge change is complicated, but de-implementation is also very complicated, as I've spoken to before. And these concepts go together because we know that science works in a stepwise fashion, and that at times we reach walls that show us that we've been wrong, and we have to pivot and really change our constructs, change our conceptual frameworks, and can change our foundational understanding of things sometimes. So implementation and de-implementation are always happening. And some of the factors that I thought of that are, I think, interesting to reflect on that may affect whether or not evidence is implemented by a group of providers that share either certain characteristics, training, or identity, surgeons versus primary care providers, physical therapists versus other providers, are the following. Where it is on the evidence-based hierarchy, what type it is, but also the quality of evidence in relation to the foundational assumptions or the foundational assumptive understanding of the causes, effects, and mechanisms of both the entity that we think we're treating as well as the treatment that we are implementing. The impact of the article, how is it spread on social media, who was talking about it, who authored it, was there press releases, the ease of adoption, how easy is it going to be to implement these findings, does it go against current understanding or practice? Conversely, does it fill, for example, does it fill a vacuum where there's not a lot of robust or effective treatment strategies or interventions for a high burden population or a high burden diagnosis, things that have really high mortality, conditions that have really high symptom burden or a lot of multiple symptoms, diagnoses in patient populations that are difficult. Is the intervention trendy or cool? Does it seem neat? I mean, we want to do things that are cool. That's we're human beings. So if it seems cool, something like that, we may be more likely to implement. Was it a huge breakthrough, or was it a discovery that kind of reached threshold that had been building over time? And I think there's like 4 possibilities here, right? So one is that was a huge breakthrough, and then so that would either potentially lead to it being uptaken very rapidly because of high press and whatever else, or it could be very slow to be implemented because it goes so counter to previous belief, previous evidence, and previous understanding. The same is also true of something that reaches threshold. Changes that are made slowly are sometimes not noticed as readily as big leaps. The flip side of that, if changes have been made readily, maybe people have been slowly accepting this over time, and you can, to induce an old cliche, the straw that broke the camel's back is that last very well-designed, multi-center, a lot of participants, greatly designed, perfect RCT that, of course, comes out all the time. Payment structure and incentives definitely affects behavior. If insurance companies start paying for something or not paying for something, that will absolutely influence our behavior, unfortunately. And I think at the end of the day, all of this to me relates to and illustrates the complexity of evidence-based practice theoretically and foundationally, but as well as the complexity of evidence-based practice practically at the clinical level, applying that evidence to an individual. And all of that interacts with both incentives and behavior change. And so I apologize for the error in interpretation on that statistic in a previous Coffee with Kyle. I thank Kenny Veneer for pointing out that kind of error or narrow thinking or kind of overly packaged headline statistic. And I really learned something by reflecting on this, and I hope that you all learned something by listening to me wax philosophic about it. So it was good to see you. Have a great evening. Until next time.